All right, as you're filing in here, I want to just say welcome to everybody. And I'm going to let people come in and then I'll start talking in just a little bit. But if you're here for the Medicaid Insights Colloquium, you're at the right place. Welcome everyone to our September session of the Medicaid Insights Colloquium. We're really excited to have you with us. We're going to give it a few moments for people to finish filtering in and then we will get started. All right, hello everybody and welcome to the Medicaid Insights Colloquium. Or Mike. Thank you to everyone who's here for tuning in, and I think we'll probably get a few people filing in as I talk. I am John McConnell. I am the director of the Center for Health Systems Effectiveness at Oregon Health and Science University. And as usual, I'll start by going over a few quick notes for our time together today. So this session is going to run for about an hour. It's going to include about 40 minutes of presentation, followed by 20 minutes of Q&A. Because there are many of you joining us today, we're going to ask that you refrain from using the raise hand function. Instead, if you have a question during the presentation, which we really encourage, you can submit it at any time by clicking on the Q&A button at the bottom of your Zoom window, and we'll get to as many questions as we can after the presentation, but we really like to hear from the audience. I want to take a quick moment to recognize my fellow members on the Mike Planning Committee for their continued work in planning these events. So please join me in welcoming our new committee member, Dr. Megan Cole-Brahim. Dr. Cole is faculty and division director in the Division of Health Policy and Insurance Research, HPI, in the Department of Population Medicine at Harvard Medical School and the Harvard Pilgrim Healthcare Institute. Also, Will Shapiro is here, and he is an assistant professor in the Division of Health Policy and Economics of the Department of Population Health Sciences at the Joan and Sanford Weill Medical College of Cornell University. So thanks to them. And now I have the great pleasure of introducing our featured speaker, Dr. Jane Zhu. I'm really excited to have Jane here. Jane is one of our own. She's an associate professor of medicine in the Division of General Internal Medicine at Oregon Health Science University here in Portland, Oregon. She is also an affiliated faculty at our center, the Center for Health Systems Effectiveness. Jane's research centers on healthcare access and quality, particularly for mental/behavioral health services, as well as the effects of provider incentives and organization on healthcare delivery, including a lot of very work on private equity. Jane has a real nose for developing research that has a high degree of policy relevance. Her work has been picked up regularly by the New York Times, CNN, Bloomberg, as well as being used directly to craft legislation and regulations. Dr. Zhu is here today to share her particular perspective on Medicaid and mental health. That's an area where there's a lot of interest nationally. So please join me in giving a warm welcome to Dr. Jane Zhu.
Hi, everyone. Can you hear me?
Yes.
Great. So I'm going to go ahead and share my slides. It's so great to be here today. Let me see if I can. I had it all set up and now see if this is right. All right. Let's see. Whoops. Okay. What are you seeing now?
We see the presenter view, so the slide and the notes view. There, that looks good.
Is that right? Actually, sorry, hold on. All right. Why isn't this working? Okay. I'm just going to go ahead and do the are you seeing the right?
That looks good.
That does? Okay, great. Well, it's great to be here today. Sorry for that technical difficulty here. I am really grateful to John and to the Mike Committee for inviting me to talk about supply side constraints in Medicaid behavioral health. This is a really topic of that's near and dear to my heart for a couple of reasons. One is I'm a primary care provider, and as many people have noticed and documented over the years, primary care providers are increasingly serving as de facto mental health providers. And I've had many Medicaid enrollee patients who have suffered from the consequences of of provider churn, not knowing where to go, attrition, and supply side issues. And so I'm going to start with this figure here. This is from a 2022 Health Affairs paper led by John that used national Medicaid claims data, TAF data, to examine mental health visit rates across state economic areas. And these state economic areas are groups of contiguous counties within a state with similar economic characteristics. So the figure on the left shows the SEA, or state economic area level correlation between emergency department and outpatient visits for mental health conditions. And as you can see here, some regions like Steubenville, Ohio, Duluth, Minnesota, had above median levels of both ED visits and outpatient mental health visits. And so one interpretation of this data might be that you could have high rates of both ED and outpatient use because these regions have high population mental health needs. But a second possibility is that these regions have reasonable access to healthcare, and there may be gaps in quality of care. So you might see some of these needs addressed in the outpatient setting, spilling over into the emergency setting. The figure on the right disaggregates the emergency room visits into two diagnostic groups. One is for anxiety and fear-related disorders on the x-axis, and the other is schizophrenia, psychotic disorders on the y-axis. And as you can see here, aggregating mental health visits can mask important heterogeneity in utilization across conditions. And so we see that there are certain areas, large urban areas, Jackson, Mississippi, Charleston, South Carolina, St. Louis, Missouri, that have a concentration of high ED visit rates. And then there's other areas that have high anxiety-related emergency room use. And the regional correlation between these two sets of visit types was actually quite low. I often start here because I think this snapshot really illustrates that local contexts shape behavioral health utilization and outcomes in very different ways. And much of that is going to drive what we discuss in the rest of this presentation. So the availability of national Medicaid data really allows us to now ask questions like, why is there so much variation in healthcare utilization for mental health conditions? A place like Butler County, Ohio, has twice the rate of emergency room visits for mental health conditions compared to right next door in Dearborn County, Indiana. And these questions have really been examined in other areas of healthcare with researchers really working to disentangle these patient-specific factors that drive healthcare utilization, things like health preferences, health conditions, from place-specific factors, things like local delivery systems, state Medicaid policies. And what researchers have found in other areas of healthcare is that about 40 to 50% of this variation is due to patient-specific factors. The remainder is due to these place-specific factors. And we know relatively little about what place-specific factors drive high quality, good outcomes in mental health care. And so I'm focusing today on this one important piece of these place-specific factors, which is the availability of mental health providers. So this is supply. This inverted triangle model really helps us to illustrate sort of the layers of constraint. So at the top are the overall supply of behavioral health providers, all that are available. Not all of them are licensed. Fewer of them still accept insurance. Fewer accept Medicaid, and then within Medicaid, only a subset contract with managed care organizations. And finally, only some of these providers are actually available to see patients, meaning they're seeing new patients and actively offering timely appointments. And so, how the workforce is distributed, how state Medicaid contracts are structured, how local delivery systems are organized. All of these are what makes the same bottlenecks play out differently across geographies. And so I won't belabor this this debate that's happened and continued within the mental health care world, but there's continued debate about whether the main constraint in the mental health delivery system is a behavioral health workforce shortage versus an aggregate shortage versus a misallocation of providers. And so this map is from Andrea and colleagues in the American Journal of Preventative Medicine, and they document using M.P.P data that about half of U.S. counties, overwhelmingly rural counties, had no practicing psychiatrists as of 10 years ago. And overall distribution was highly skewed towards metropolitan areas in particular. And other research that has followed has suggested that there are pockets in the US, like in New England, Massachusetts in particular, where there's a relative oversupply of psychiatrists. So there's certainly subspecialties like child psychiatry, where the training pipeline is very narrow and limited. But these data suggest that a very real constraint may in fact be maldistribution, not just by geography, but by payers as well. We used Oregon claims data to look at this question of the geographic distribution of behavioral health providers, and we find that utilization is uneven across different types of providers. So this map shows essentially how hard or how easy it is to reach different types of behavioral health providers using a GIS method that takes into account both where providers are located and how far patients might have to travel. And then we compare that relatively to other zip codes, so other areas. And what this generally shows is that in urban areas in Oregon, most zip codes have high access to both types of providers, prescribers and non-prescribing mental health clinicians. But in rural and frontier areas, this picture looks very different. Nearly all frontier zip codes actually fall into the lowest access group for prescribers. But surprisingly, on the right-hand side, some frontier areas actually have relatively good access, better even than some urban areas, to non-prescribers, suggesting that there is heterogeneity in how different provider types are distributed. I think one of the perennial challenges in understanding this question is really related to sort of the different difficulties in quantifying the behavioral health workforce. One of the reasons is that the workforce is highly variable. There's lots of different types of providers with often overlapping roles. Understanding what constitutes a sufficient workforce also requires us to understand how to match patients to the right providers. And that often depends on factors like the type and severity of illness, what treatments are indicated, therapeutic alliances with providers, and that's very hard to measure. And finally, Sherry Gliad and others have argued that current designations of problem areas are really lacking differentiation. And as a result, it's really hard to know where to target policy levers, where to prioritize policies. For example, 88% of counties are designated as mental health professional shortage areas, aggregate shortage areas, and that makes it very difficult to know what to do first to address this issue. So in Medicaid in particular, one of the most important binding constraints that's been reported has been low insurance acceptance. Across multiple studies, national studies across specialties, psychiatrists have consistently been found to have the lowest insurance acceptance rates of any specialty. Roughly 50 to 70% of psychiatrists accept any insurance, which is lower than any other specialty. Medicaid acceptance tends to be the lowest, about 35 to 40%, and that has been shown to be downtrending over time. Why is that? Reimbursement rates are often cited as a factor by providers and anecdotal information by policymakers. And there's very well documented disparities both between payment for behavioral health and medical services and between Medicaid and other payers. But robust evidence on the payment access link is actually quite mixed. The majority of studies that have looked at this topic and looked at this question have primarily leveraged temporary ACA fee bumps to understand the effects on primary care acceptance of new Medicaid patients. Very little has been done on the behavioral health workforce, which is unique in many different ways. And the brunt of that evidence is far from conclusive. When we look at Medicaid rates in Medicaid, reimbursement rates in Medicaid in particular, we find that for psychiatric services, Medicaid pays on average about 72% of Medicare rates for the same set of services. And there's a lot of variation at the state level. We find about an 8-fold difference in the fees paid to psychiatrists by the highest and the lowest paying states. And we also find, although this is purely descriptive, no clear correlation between Medicaid reimbursement rates and the supply of Medicaid participating providers. One potential explanation for this is the fact that behavioral health providers have historically had access to a very robust cash pay market. And that presents obviously clear alternatives to not only accepting Medicaid, but to accepting any insurance at all. And we tried to get at this question descriptively by web scraping a large national online directory of about 175,000 psychotherapy providers. This is a patient-facing consumer directory called Psychology Today. And that includes therapists, psychologists, counselors, social workers that practice in private practice settings. We found that among these providers, about 35% accepted any insurance, and that those accepting insurance have lower cash pay rates than those who don't. And further, the average difference between cash pay rates and Medicaid fee-for-service rates across the sample was about 40%. And I think obviously underestimating that gap. In some states, those differentials were quite large. Research from other fields has shown that other than payment itself, ease of payment contributes. And so when we're talking about administrative burdens, of billing, payment delays, other hassle factors, this is an emerging area of research. We see that this may have just as an important role in driving provider decisions to accept Medicaid as payment itself. Abe Dunn conducted a recent study using all-payer remittance data to quantify this barrier, and he found that about 24% of Medicaid claims have payment delays compared to just 7% in Medicare and 4% in commercial insurance, and that corresponded to 18% less revenue for the providers. They also found that a 1 standard deviation increase in incomplete payments reduced the probability of accepting Medicaid payments by almost 1 percentage point. Other factors have been less well described, but have been described anecdotally and in surveys of providers, interviews of providers. And those include clinical complexity and acuity, the fact that Medicaid patients often have greater health-related social needs that are not well compensated and supported by current structures, and then things like market and practice structures that are not well investigated. We've interviewed behavioral health providers practicing in community mental health organizations to understand what exactly might be driving attrition, burnout, exit from the Medicaid program. There's been some early data showing churn of Medicaid providers in and out of the program. Our informants highlight a number of additional burdens that are very much specific to Medicaid, including documentation burdens. For example, a Medicaid provider who is seeing a new patient has to have a full diagnostic assessment visit before any treatment services can be rendered and paid for. So they have to see this patient, maybe they're in crisis, they have to go ahead and schedule another visit, and the patient has to come and show up for another visit before they can actually, the providers themselves can be paid. They cite poor administrative and physical infrastructure, including insufficient support to manage high rates of no-shows, coding, billing, credentialing. There's lack of career development opportunities with insufficient training. Younger providers out of school are often the ones that come to these Medicaid anchor agencies, and they're often ill-equipped to deal with the sickest patients, and supervisory positions are unsupported. Further, our interviewees reported really just these chronically traumatic work environments. There's productivity expectations to meet revenue goals, there's understaffing, there's high needs, and then there's also often worries about personal safety in the clinical setting without adequate support. And so one interviewee characterized this as Medicaid relying on the goodwill of providers, that certain sets of providers, those that are very much mission driven, are drawn to the program, but they're not given sort of the fuel to continue often in the program. So despite the lack of clear evidence in this area, the policy implications are quite significant. Kaiser Family Foundation conducts surveys of state Medicaid programs on a regular basis. And in a recent iteration of this survey, they found that 39 states have reported increases for behavioral health providers in 2023 and in 2024. Often these are in the form of fee-for-service supplemental payments, which states are allowed to make to providers up to the average commercial rate for physician services in that market, or they might do this through state-directed payments that MCOs are allowed to distribute, often to establish a minimum payment rate for certain types of providers. As part of a new grant that we currently have to evaluate the effects of some of these policies on behavioral health provider participation in Medicaid, we've conducted a document review, a landscape review, looking specifically at Medicaid documents at the state level and MCO level documents. And we found that, in fact, between 2020 to 2025, every single state had at least one behavioral health reimbursement policy change. Most of these changes have been reported as explicit policy decisions that are that go beyond cost of living adjustments. The majority, however, are piecemeal rate changes. So they target specific billing codes, they target specific provider types or settings. States are doing lots of different things, which presents a unique opportunity to study what approaches might work and which might not. For example, this is just a few selected state reimbursement policies that we've found. Kansas has specifically targeted psychotherapy and assessment codes. North Carolina passed broad increases of about 13 to 35% across different sites of service and settings. And Oregon, my home state, has implemented one of the most ambitious reforms trying to increase access to behavioral health services in Medicaid. Roughly a 30% behavioral health across the board rate increase with additional directed payments specifically for Medicaid heavy providers and culturally specific services. So we know a lot about potentially misallocation of behavioral health providers. We know a lot about low insurance acceptance rates, but we still don't know a lot about how reimbursement, administrative burdens, other hassle costs drive decisions to accept Medicaid more broadly. States are often turning now to a common set of policy levers, but the net effects of these policies are unknown and really are, in my opinion, likely to depend on how reimbursement policies intersect with these other barriers. So turning now to Medicaid, managed care contracting and provider networks. The audience here knows most Medicaid enrollees are covered by managed care plans, and managed care is really a great strategy for plans to contain costs for individuals with complex needs, including those with mental illness, substance use disorders. And there are several functions that these organizations perform that are relevant here. So one is establishing provider rates and payment procedures. For example, it is in fact MCO rate setting and state-directed payments through MCOs that often shape what providers receive. Monitoring of covered services and use, including gatekeeping restrictions like prior authorization, referrals. And then obviously of interest to me is establishing limited provider networks that can often restrict beneficiary choice of in-network providers and facilities. And network design can serve as another direct bottleneck to the supply of behavioral health providers and often is overlooked and understudied as a feature of managed care. And so this is a direct link between coverage and access. A potential benefit of narrow networks is to help insurers direct patients to lower cost and higher quality clinicians. And research suggests that in other markets, for example, ACA individual marketplace, patients often tolerate this trade-off in exchange for lower premiums. But in Medicaid, there are potentially different effects here because enrollees often don't pay premiums. There are no cost sharing expectations. And so these trade-offs might exhibit differently with, for example, plans being less inclined to go into areas where costs might be higher or networks might not serve their functions. And then research also suggests that narrow networks generate hassle costs, including by a prior speaker here at Mike, Jacob. And so, these hassle costs lower utilization, they lower healthcare spending, and they may limit access to care. We've used a variety of data sets to look at these networks. So across Medicare Advantage, Medicaid managed care, and ACA marketplace plans, we find that psychiatrist networks are often amongst the narrowest. This figure is from a Health Affairs paper in 2023, which shows that in Medicaid managed care, this is the red bar chart, about 40% of plans are narrow networks for psychiatrists, which means they include fewer than 1 out of every 4 psychiatrists that are practicing in a county service area. So in other words, even when psychiatrists exist, many are not contracted with health plan networks, leaving enrollees with limited choice. We used Oregon Medicaid claims data to dig into this a little bit further to understand how provider networks are comprised. And in Oregon, provider networks are mostly non-prescribers, non-prescribing clinicians. The majority of mental health visits are also conducted with these non-prescribing mental health clinicians, which include psychologists, social workers, behavioral health counselors, and therapists. And further across plans, the ratio of prescribers per 1,000 mental health patients is largely restricted. It doesn't change across plans. But where Medicaid MCOs differ the most in Oregon is their inclusion of these non-prescribing mental health clinicians. We can also use Medicaid claims data to look at other MCO level frictions. So many of the same frictions that limit insurance acceptance broadly, claims processing, credentialing, and onboarding delays also shape specific MCO contracting decisions. When we look at time to payment, for example, in the TAF data, we see a lot of variation in processing time, with some MCOs consistently demonstrating lags. In ongoing work, we find evidence that this variation isn't driven by anchor services or types of services, but by MCOs, with MCO variation further constrained or shaped at the state level. And market structures may also influence provider networks and the availability of providers ultimately to patients. So the map here shows that a majority of counties with MCO presence have at least 2 MCOs that overlap in the same coverage area. There's been a couple of studies that look at other payer markets, and they've shown that conditional on participation in Medicaid managed care networks, there's actually a high degree of overlap with other payer markets. So that means that not only are networks narrow to begin with, but they're also not exclusive. So participating providers are simultaneously serving other Medicaid MCOs as well as enrollees from other payer coverage from other payers. These dynamics are supported by, again, qualitative interviews, which we've conducted with MCOs themselves. We have one recent study that interviewed 27 MCOs across different regions, profit structures, coverage areas, including 2 of the big 5 health plans in Medicaid. And we learned that plans are essentially anchoring their networks around a small core of Medicaid-focused behavioral health providers. these often overlap and compete with other networks when supply is constrained, which is what we're seeing signals of in the Medicaid claims data. To address these issues, MCOs reported directly supporting workforce supports, so training programs, enhancing rates, employing telehealth and mobile units to reach underserved areas. Many are using intensive case management to better match members to specific levels of care or providers, especially where higher acuity services are not available readily. And finally, MCOs are emphasizing that state policy environments are largely determining, the menu of options that are available to them. So rate setting, reimbursement rules, credentialing requirements are constraining or enabling some of their strategies. All right, so what do patients see at the end of this inverted triangle? We used all payer claims data in Oregon to assess differences in access for Medicaid and commercially insured individuals across a variety of provider groups. And so the figure on the left shows the share of Medicaid patients by provider types that are listed here, with each dot representing an individual provider. And then the distribution of these providers are density estimates. And what we see here is that unlike other provider types, payer mix distribution amongst mental health providers in particular is bimodal. There's large densities at either tail, which suggests distinct polarization in payer mix at the provider level. So there are groups of providers that are disproportionately caring for Medicaid patients, and those who are largely avoiding Medicaid altogether. Traditional sources of provider network data like provider directories, regulatory filings we've even looked at are overstating provider networks by a substantial margin. We obtained Medicaid MCO plan directory listings through the Freedom of Information Act in our state, and then we compared Medicaid MCO plan directory listings to administrative claims data, and we found that about 2/3 of mental health prescribers, so psychiatrists and nurse practitioners, and about 60% of non-prescribers don't file claims for any Medicaid patients, despite being on the surface enrolled or contracted with these MCOs. And then interestingly enough, when we also found some substantial variation in the presence of these ghost providers across plans, and this variation didn't seem to be associated at all with population characteristics, base rates of utilization, plan enrollment, network size, and instead appears to be driven by administration and operational aspects of managed care organizations themselves. When we look nationally, we see this pattern is true across specialty types. So there are high shares of physicians enrolled in Medicaid that are ghost providers, including 43% of psychiatrists, which is the highest across the specialties that we've looked at. The median psychiatrist, when we looked at the claims data, who bill for Medicaid patients, saw just 3 unique patients in 2021 and billed just 7 encounters, and that contrasts greatly with concentration of care for other specialty types. So these descriptive data reinforce a couple of points. So one, that many contracted providers aren't actually taking care of Medicaid enrollees, narrowing the funnel further, and care is concentrated among very small subsets of core providers, meaning that the departure or the churn of an anchor provider can have really outsized effects on Medicaid patient care. And so what patients see, which is unsurprising, is long waits and poor access. So this is a secret shopper study published by Will Shapiro last year, in which they called a bunch of clinics or psychiatrists across markets, and only about a quarter of sampled clinicians had an appointment available, with median wait time stretching from less than 2 weeks in Phoenix to more than 2 months in Los Angeles. So unsurprisingly, if providers have very low Medicaid engagement, care is concentrated, access is going to be uneven across these different areas. So what we still don't know is, and what we're working on, is what the causal effects of network design and MCO policy variation on outcomes are. We lack standardized and often useful measures of provider capacity, panel size, and turnover impacts in the claims data. A lot of access has to be done through methods that Will has demonstrated, for example, in secret shopper studies, and they don't always reflect what patients see. And finally, we don't really know how expanded capacity, for example, if caseloads change, or if we include telehealth as a modality, if that affects access and quality, and particularly if that expands access to new patients. And the clear policy implications here relate to efforts that regulate what constitutes an adequate provider network, so network adequacy standards. And historically, CMS has centered on using time and distance standards for specific types of providers. There's been some additional flexibility over the years, offering states the opportunity to develop their own quantitative as well as qualitative measures for network adequacy. But research by Chima and Dumoulin and others have found that adoption of these prior network adequacy standards have really had very little effects on access to care. And so our research talking to MCOs has shown that there is, number one, a huge lack of enforcement in this area, and that to the extent that these network adequacy standards affect anything, MCOs report that they affect their decisions to actually enter into markets. For example, one of the big five MCOs that we talk to, companies that we talk to, said that if they know that they're not going to be able to fulfill network adequacy standards in a particular area, they just don't enter that market. And so there are substantial opportunities for researchers to evaluate this changing landscape of regulations. CMS in 2024, in their Medicaid and CHIP managed care final rule, established for the first time federal wait time standards in Medicaid. So 10 business days for routine outpatient mental health and substance use disorder visits. They also now require annual secret shopper surveys and enrollee experience surveys to validate wait times and directory accuracy. They require corrective action plans if states fall short. And then there are new payment transparency rules on how MCO payment rates compare to Medicaid fee-for-service. This is a black hole right now for us, and as well as to Medicare. And most of these provisions phase in between 2026 and 2028, leaving lots of time to implement. And so finally, because it relates to other areas of interest for me from a research standpoint, there are lots of additional unknowns that are potentially affecting provider supply with changing markets and practice structures that we don't yet know about. So John mentioned that I do some research looking at ownership transitions in healthcare. And what we've looked at this in mental health and substance use, we found that there have been an increasing number of mental health facilities and substance use facilities that have been bought by private equity firms that are really focused on high rates of return for their investors, short investment timelines, and typically they follow a playbook of rapid consolidation, both within and across markets. And so we see that about 6 to 8% of all of these facilities are now owned by private equity nationally, and that this varies substantially by states. For example, in Colorado, about 40% of mental health facilities are now owned by private equity. 24% in Texas, 23% in North Carolina. So the implications of these ownership changes and how private equity and other corporate owners consolidation is affecting provider supply, who they choose to contract with is yet unknown. In addition, there have been now trends towards these new national telehealth companies that are increasingly employing new providers out of school and recruiting providers out of their former practice settings. And so these, anecdotally, when we talk to providers, we hear stories of sort of recruitment and retention strategies that these companies are using and how successful they've been. We are currently interviewing providers, behavioral health providers that are working for these large companies. And we're hearing repeatedly that this is a question of administrative tasks that they can handle, back office billing, and then, of course, billing rates. So guaranteed income, despite the fact that these companies often take a large cut of the actual rates that the providers are seeing. So providers are willing to pay for the stability of the rates, despite not necessarily having, top market dollar for their services. Okay, so research considerations, I want to leave time for questions. Research considerations as we're working through some of these larger questions. The effects of a lot of these policy levers that states are increasingly turning to are likely heterogeneous. And that is, I think, the key to targeting resources efficiently as we conduct research in these areas. We are using TAF data, which offers a lot of promise for studying issues of access and participation, but persistent data gaps exist. I can talk about this a little bit more, but we've, for example, experienced lots of hiccups and challenges with provider identification, missingness, data quality issues that limit the precision of these analyses. We know that directories and network files often misstate availability. And just as policy is moving towards understanding better beneficiary experience and realized access, so should the research. And then finally, I've sort of run through some early descriptive data, but we are trying to assess causal evidence. So there is a great need for causal evidence on how things like network design, provider participation shape outcomes, and how state and MCO level policy variation interacts with that and also can be leveraged to improve outcomes. I want to thank the many people that are working on these projects with me, including John here, and others that are in the audience. And then specifically a data and infrastructure shout out that might be useful. So the TAF data, as many of you are aware, there's lots of learnings that have been shared through the Medicaid Data Learning Network, through the Center for Health Systems Effectiveness. There's now an MCO crosswalk that Connor and others have worked on to help link claims data to specific MCOs, and this is available freely through this GitHub, and that QR code will get you to those managed care crosswalks that you can use in your research. I'm going to stop there, and thanks again for your engagement and participation, and happy to answer any questions or open up for discussion as well.
Thanks, Jane. That was really fabulous, and a lot of information there. So wonderful. And so yeah, we've got and maybe you can close your slides there so we can just see that the two of us are stop sharing your screen if you can do that. So we got a couple questions from the audience, and so I'm gonna give those to you so we can get those answered. The first one might sound simple, but it's actually there's some nuance here. So I'm gonna give this to you and let you take it. What specific mental health providers are included in Medicaid TAF data? They're asking for 2018, but I think it's probably generalizable across years. You want to talk about your effort to kind of sort some of this out?
Yeah, this is a really great question, and it's definitely been both a challenge, but also an opportunity. So we've found through looking at the claims data that there's a lot more reliability in terms of physicians that are consistently billing for mental health services in comparison to non-prescribing mental health clinicians, as you could imagine. But there are also some structural issues that vary state by state. So in some states, for example, they don't report MPIs. for billing or servicing providers in the TAF data. And instead, they might have state-specific provider identifiers that don't always link to MPIs very easily. So that's one challenge. Another challenge is there are certain and actually very common cases where the billing provider or the servicing provider is actually an organization rather than a billing individual. And that obviously introduces lots of complications when you're trying to understand provider networks at the provider level, the individual clinician level. And this has varied. When we've looked at the claims data, this varies greatly by states. There are some states where the majority of claims are billed by MPIs that are organizations rather than clinicians. And so we've had to use, certain thresholds to try to, get around that, or to basically exclude those states because we can't get a very comprehensive picture as to, who individually we're looking at. So mental health provider types, though, you can use MPPES or NUCC categories to group providers by their provider type. So we can see, for example, where they exist: psychologists, social workers, therapists and counselors, as well as all sorts of prescribing clinicians like NPs and others. And then the last point I'll say is that increasingly, and this has been shown by Ativ Malhotra's work in the Medicare setting, but increasingly nurse practitioners have been serving as specialty mental health prescribers. And they are particularly difficult to identify in claims for various reasons. One is scope of practice laws, of course, and the other is that even in places where there is full scope of practice for nurse MPs, they often bill under a physician because physician rates are higher. And then finally, in the M.P.P.E.S. data and categorization of nurse practitioners, there's actually very limited there's a limited number of nurse practitioners that will be accurately categorized as psychiatric. Mental health nurse practitioners are often instead labeled as general nurse practitioners. So we have adopted Ativ's work that has sort of used utilization, so prescribing patterns, to then further identify nurse practitioners in particular, and then to look at potentially incidental billing using claims data. So those are really great models if you're looking to capture a wider range of mental health specialty providers in your research.
All right, that's great. Great question and great answer there. We're going to move up the Jeopardy board in terms of difficulty, since you had such a good time answering that one. So here's one that's tricky, but you can speculate. So can you talk about existing work on mental health outcomes among Medicaid beneficiaries on managed care versus fee-for-service plans? Is there evidence that MCO beneficiaries with mental health conditions have worse mental health outcomes under MCOs, with the hypothesis that MCOs are most focused on cost controls instead of long-term population health outcomes, and have more limited provider supply because of in-network requirements than fee-for-service plans? So any speculative stuff there, or any evidence you want to put forth?
This is a long question. So I think the question is asking if we have, or if I've seen any existing work on mental health outcomes, the actual outcomes in those participating in managed care. Yeah, I mean, John has worked a lot on this as well, and others that are present in the audience. The data on outcomes and how that varies by managed care is far from causal. There's very little robust evidence, but there are trends that suggest that managed care plays a role in utilization. So John has some, is it okay if I review
Sure.
John? So John has some early evidence looking at, for example, adolescent healthcare, adolescent populations that need mental health care. And he's finding, for example, lots of variation by managed care organization in their utilization rates. And so we're far from seeing definitive understanding of what specific levers. Is it the utilization management? Is it the managed care organization structure? Is it for-profit versus, nonprofit status? Or is it provider networks? What exactly is the mechanism by which these outcomes or the utilization might differ across plans? But there's certainly a lot of appetite for this, not only amongst, you know, patients and policymakers, but among managed care organizations themselves. Like they want to know what works to improve, their health enrollee, their enrollees' health in their organizations, because there's a financial and hopefully a mission-oriented reason for doing so.
Yeah, yeah, it's a great question. And if you're not familiar with Jake Wallace's work, he was here, and you can find it in different ways on the web. But he's done a lot to sort of try to suss out some of the difference between fee-for-service and managed care work, not on the mental health side, but just generally. Okay, more questions coming in. So here's another one that we've talked about recently. Jane, maybe you can see this. If a state has multiple statewide MCOs, does it seem providers are less likely to accept Medicaid due to the hassle burden as it is multiplied?
This is a great question. I mean, I think that's exactly, John and I were just talking yesterday, and this is exactly the question that we want to answer. And then, obviously there's lots of appetite to answer this question. So what we're seeing is certainly not only multiple statewide MCOs, but in terms of contracting practices, the way that Medicaid MCOs, especially those with other insurance products, often get people to enroll, the providers to enroll or contract within Medicaid is by dangling other insurance products in front of them. So they often do a single sign agreement where in order to practice or contract with their ACA plans or their private commercial plans, they have to contract on paper with their Medicaid plan. And so we often see for those reasons, and what we see in the data is lots of overlap, not only within the Medicaid program, but also across insurer markets. So it is very much possible that this is a hassle cost that has not been quantified, but that's exactly that. Like this is just theory, and I don't have any conclusive evidence that that's the case.
Yeah, great question. So here's another one. I know you've got a lot of ideas on telehealth. You went through them pretty quickly, but this is a chance to expand a little bit. So here's the question. With behavioral health care increasingly relying on telehealth, how is the picture changing, and how should telehealth-based providers be considered in network adequacy analysis given the distance and travel time no longer apply?
Yeah, I mean, this is a great question, and actually one that a lot of MCOs and state policymakers are struggling with. When we talk to Medicaid MCOs, they essentially, across multiple states, and it depends on the state, they are given it counts towards, a credit, essentially towards time and distance standards if they have telehealth providers. But the way in which these MCOs, at least anecdotally, are reporting contracting with telehealth providers is really varied. So some are really focused on expanding telehealth as a modality within the providers they already contract with. So you can imagine in those cases that maybe access is not necessarily going to be broadened because the capacity is not broadened. You're just basically you're replacing in-person with telehealth visits. In other cases, we've heard from MCOs that are explicitly contracting with national telehealth companies in Medicaid in order to fulfill network adequacy requirements where the supply does not exist locally. And I imagine that those contracting practices would look different. When we've looked at in the claims data, one question that we've asked is how have providers changed their practices now that telehealth comprises a large share of behavioral health visits in Medicaid. And what we see is that when we look at providers that were in Medicaid in 2019 and then providers that remain in Medicaid in 2021, sort of post-COVID, after the telehealth adoption change, that a very substantial portion of non-prescribers in general, so psychologists and counselors, have now gone to 100% telehealth. And then we've looked at sort of the spatial density. So has that, and this is early work, has that changed who they reach? And the short answer is it doesn't seem substantially that they are actually capturing people that are located further away than where their patients were before, suggesting that a lot of these telehealth only providers, the switch from in-person to telehealth, has just been sort of a replacement rather than complementary to the care that they would otherwise be providing in person. So these are all really important questions that we should be grappling with, and really no solid evidence on this yet.
Yeah, it's fascinating. Okay, another one. This person says, thank you for the seminar. That was great. To what extent do these supply side issues persist when Medicaid beneficiaries age into Medicare?
Great question. So that Mark Meiselbach and others at Hopkins are working on Medicaid. John Graves, for example, they're looking a lot at Medicare insurance networks. When we've looked at Medicare Advantage in particular compared to Medicaid managed care, we actually see that Medicare Advantage networks for psychiatrists actually are even narrower than in Medicaid managed care, which is both surprising, but also maybe not surprising, because there are a lot of other factors at play in terms of maybe where older beneficiaries prefer to get their care, the stigma attached to behavioral health conditions, as well as sort of managed care profit incentives and cost considerations. So the Medicare Advantage and older population, as well as actually the younger population within Medicaid, adolescents and children are definitely sort of unexplored in terms of how supply side issues affect their care. And I would definitely encourage people to look into that further. We
Great.
need research there.
Yeah. And then the last one, I think you shared a little bit about this, but maybe you can recap it. So the question is, do we have any nationwide data regarding the prevalence of behavioral health ghost providers and networks? Does this vary by region or state?
Yes. So one of the slides that I shared looks at behavioral health ghost providers, but defined in Medicaid writ large. So one of the challenges in actually looking at provider networks nationally is that you need some denominator, and you need that in the form, and you need a numerator and a denominator, and you need that in the form of plan directories or who the managed care networks contract with. Thus far, some of that work has been done through existing data sets like VeraCred, but VeraCred is limited in terms of its coverage areas. And then Chima and Dumile and Will Shapiro have actually, and others have looked at specific states where they're able to get, through partnerships with states, managed care plan directories. Interestingly enough, with the new managed care rules, plan directories are supposed to be they're supposed to be publicly available, but we've had to rely on, again, Freedom of Information Act to get this information in our state, and not all states will respond to this. But it is essentially, the reason it hasn't been done at the network level is because it's a lot of legwork to find all the MCO plan directories for every single MCO. Sorry, long story short, we don't have nationwide data specific to MCOs, but we do, through the claims data, have data on provider participation and a level of participation activity, so the intensive margins, within the Medicaid program more broadly.
Great. Thank you. Okay. Well, this is a wonderful presentation and great information there in the Q&A. That's all we got time for today. So thank you, Jane. That went fast, but was really great. And thanks to everybody here. We really appreciate you joining us. You'll be receiving a 2-question survey about this session to help us continue to make the program better. And our next mic will be November 12th, and we're going to hear from Hannah Maniatis from the National Association for Medicaid Directors. I think she'll have a lot to tell us about how they're thinking about Medicaid, Medicaid reform, and so on. So don't miss that. Make sure to stop by and RSVP at the series website, medicaidinsightscolloquium.com. Great to have everybody here and hope that you have a great week. Thank you.